guys that don't know me, I think I've worked with pretty much everybody because I've made it through her. I'm Anna, and I am teaching you guys pharmacology, and I tried to cover mostly what was in your book versus any other source, and I reviewed the questions at the end of the chapter and kind of tried to stick to that level. Hopefully that'll be adequate. Have you guys heard any feedback about that, or what you think?
Great.
Get a word out. Okay. And to be honest with you guys, a lot of this material is what I had to learn in nursing school. So to your credit, this is a large undertaking. And you will be wiser and smarter than they will give you credit for when this is all over. So kudos for that. I am going to go over, I'm going to start with pharmacokinetics and dynamics because there's some vocabulary words in there that'll help us talk about the other drugs. There's also quite a bit of the book dedicated to those two topics individually. Then the big three areas they seem to focus on in other chapters were CV pharmacology, respiratory drugs, and then paralytics. So we'll hit those highlights. All right, pharmacokinetics. So this covers how the body affects the drug. So once you give it, what happens? You have to give it, then it goes through absorption and distribution, it's metabolized, and then the body gets rid of it. So administration can occur in tons of different ways. Primarily in the OR, we're going to be doing IV. We do some sub-Q, and then we'll do some intrathecal, which is going to be your subarachnoids or spinals. Also epidural, and then we do some perineural, which is going to be our nerve blocks. One of the big vocabulary words is first pass clearance. It occurs when you take a med orally, which is what most of us take every day at home. Medicine goes in through your mouth, goes to your stomach, and there it kind of starts getting broken down and absorbed through the stomach and then also the intestines. And the way the body's laid out, once it gets absorbed into the bloodstream from that area, it goes through the liver first before it can get distributed to its target organ. So you're going to lose some of that medication just through absorption in the liver. So like I said, it equals decreased bioavailability is the key word there. But first pass clearance occurs with oral meds. It causes them to be slow onset, which is why we don't really use them. So distribution. Once you give a drug IV, it takes about 30 to 60 seconds to get well circulated in a normal human. And then it'll move to the tissues just because there's a high concentration in the blood, so it's going to therefore move to where it isn't already. It's going to move through passive diffusion to an area of low concentration. The amount that's delivered is going to be, and how quickly it circulates, is going to be based on your cardiac output. So how much blood is going through your heart and what your heart rate is. You guys have seen us have patients that have really slow heart rates, like 40 or 50, and it takes twice as long for them to go to sleep. That's why. The areas it's going to go to first are the vessel-rich groups. Those are the areas that get lots of cardiac output compared to others. So, of course, you're going to get your brain, your heart, your liver, and your kidneys. Those are all pretty dependent on blood flow. When the concentration is high enough, wherever it needs to work, is when you'll see that effect start to set in. So redistribution is generally what leads to a less effect of the med. When we give propofol, it takes somewhere between 30 and 90 seconds for it to knock someone unconscious. What causes that to quit working is that it gets circulated away from the brain. It's not that it's completely out of their system at that point, it's just getting moved away from the brain at that point. So it's going to go to the muscles and the vessel pore groups, which are what I have here, the tendons, cartilage, and fascia, which propofol does nothing for you there, so it's not particularly useful at that point. One of the questions in the book was, what leads to a decreased effect of your drug? It's not that it's metabolized, it's that it's redistributed. Elimination. This is how it actually gets out of your body. It occurs primarily through biotransformation, which is the fancy word for metabolism. A chemical process transforms the active compound into an inactive compound. It can also activate something called a prodrug, which is a drug that needs to be metabolized to some degree to be active. There's a drug, I think it's called phosphorus, that they use in some GI settings. That is a prodrug. It has to be metabolized first, and then it turns into propofol and is effective. So biotransformation usually occurs primarily in the liver. It can also occur in the bloodstream. In the liver, it's done by a set of enzymes called CYP450, and it results in phase 1 or phase 2 reactions, which is where it adds on a compound to the drug that makes it inactive, and generally it makes it easier to get out of the body. That's the majority of our drugs are eliminated and metabolized in the liver. Some of the other ones that are done in the bloodstream by plasmacholinesterases, these occur quickly. These drugs have very short acting times. It's Sux and Remy are two of the drugs that are metabolized by plasmacholinesterases, which is why Sux lasts about 5 to 7 minutes, and Remy needs to be on an infusion to really be effective because it's metabolized so quickly. In patients that have liver failure, the plasmacholinesterases that occurs in the bloodstream, those enzymes are made in the liver. So if a patient has liver failure, they're going to have a hard time metabolizing any drug because it's either got to go to the liver or it's metabolized by something that's made by the liver. So liver failure patients can end up with lots of drugs hanging around in their system. And then the drug goes through elimination, usually through the kidneys or renal clearance. They're filtered into the liver and then peed out. Renal failure patients can have a buildup of the compounds that are biotransformed by the liver. Sometimes those compounds can have some degree of activity, like morphine. So you'll see us not give morphine to those patients because they can get a buildup since their kidneys aren't working well. But liver failure patients can have trouble metabolizing basically any drug. Renal patients can have trouble clearing lots of drugs. All right, some other vocabulary that didn't fit on another slide. Volume of distribution. So that's how much of the body is the drug going to go to. Is it going to stay in the bloodstream? Is it going to move out into the fat? Hydrophilic drugs love water, so they stay in the bloodstream. Lipophilic love fat. So lipo, if you think of liposuction, lipophilic love fat. The volume of distribution really starts to affect how quickly a drug is going to work, how long it works, and then of course where the drug's going to go. But really, when you think volume of distribution, think how quickly will the drug start to work. If you've got a big volume of distribution, it's going to take longer versus a smaller. Half-life is the time that it takes to eliminate 50% of the drug from the body. What that does is it helps people guide and decide how much of a drug they need to give and how often that dosing needs to happen. It's particularly used for whatever meds patients are on at home daily. So steady state concentration. That's where you get a drug just in that happy dosage range in a patient that gives you the effect you want without any side effects or without being ineffective. The goal is to maintain that therapeutic level throughout the duration of the drug being given. You can do that a few ways. You can give a loading dose, which is a big bolus up front like we do with Precedex, and then start an infusion. So that loading dose gets you up to that range, and then the infusion helps you maintain. Sometimes you can also just kind of start the drip higher and then back down once you see the effects that you want. It's kind of to the same endpoint, just done slightly differently. Steady state concentration incorporates volume and distribution and half-life into how much you need to give. So that is pharmacokinetics in a nutshell. Anybody have questions on pharmacokinetics at this point? Just remember that's what the body does to the drug. Kinetics is what the body does to the drug. Pharmacodynamics is going to be what the drug does to the body.
One question.
Yes.
Can you go back?
Uh-huh.
So a hydrophilic drug would probably leave the body quicker than a lipophilic, right?
Yes. Because if it's going to go out to the fat, it's going to hang out longer.
Okay.
Versus if it's in the blood, it can get to the liver, get metabolized quicker, get rid of it quicker. So the way, I don't have a huge mnemonic for pharmacokinetics, but for pharmacodynamics, it has a D in it. So it's what the drug does to the body. And then I remember kinetics has to be the other one. But this is what we give drugs for, is for the pharmacodynamic part of it. What can it help our patient achieve and accomplish? So receptor theory is, I kind of think of it like a lock and a key. The receptor is on a cell. The drug is your key. It's going to bind to the lock, and then you'll get cellular activity. The receptors are the external part of the cell, which is here, and then the drug or the ligand. Ligand is just a fancy name for whatever you naturally make in your body that binds to that receptor. Because basically all our drugs are trying to mimic what already is occurring in the body that interacts with that receptor. So once the drug or the ligand binds with the receptor, then that receptor sends a message inside the cell to cause change. They're very specific. The receptors have very specific binding patterns. There are lots of people that go into pharmaceutical development that spend their lives figuring out what kind of receptor and ligand will bind. That's basically what it takes to develop a drug. Find a receptor in the body, find something that you can put in there to cause an effect. So an agonist is a drug that will bind to the receptor and cause a reaction. It can do a great job at it, a full agonist, or it can do partial. It'll do a so-so job of causing a reaction. But an agonist will bind to a receptor and equal a reaction. An antagonist will bind to a receptor and block an action. So it'll bind and generally get you nothing, which can be fantastic. If you're beta blocking somebody, you want to slow their heart rate down, you block those beta receptors and that cell can't fire and cause that heart rate to keep going as high. So antagonistic drugs can bind irreversibly, like aspirin. Aspirin will bind to a platelet and be there the entire lifetime of that platelet, which is only 7 to 10 days, but that matters for us. So we tell patients to stop taking their aspirin 7 days before surgery. By that point, that platelet will die off and be replaced by a fully functional platelet. Most of our drugs, however, are competitive antagonists. So the drug will compete with the natural receptor, the natural ligand for the body, and compete to bind to that receptor. And that just comes down primarily to numbers. What is there more of? If you've got more of one thing, the chances are going to be higher that that will bind to the receptor. So most of our drugs are competitive antagonists. Clinical pharmacology. So this is a picture from a book that is outside of y'all's tech book, but it gave a much prettier picture of a dose response curve and what we're looking for. So it kind of goes down to the lower numbers, the ED50 and LD50 down here. What we consider the ED50 is the effective dose in 50% of patients. And that's what we kind of consider the average effective dose. Now that's what will get you that result in half the people you give it to. So frequently, we'll give drug dosages that are 2 times that number or 3 times that number to make sure that we're covering more than 50% of the world when we're given a drug. The lethal dose, LD50, is what percentage of that drug would it take to kill 50% of people, which is something we try not to approach. But the therapeutic index is going to be the ratio of the ED50 to the LD50. And the therapeutic index is where you want to give your drug, is within that safe range. You're not near the LD50, you're closer to the ED50. So effective dose in 50% of people is what we want to see. Potency describes how potent a medication is. How well does it work? If you have a drug that's very potent, let's see, like epi, you're going to give less of that as a whole because it's potent. It works quickly, it works well. Or you can get down to, I'm trying to think of a less potent drug, dopamine, butamine. They're going to require less. They're less potent, so you have to give more drug to get to an effective range. So potency is nice in that it takes less to get your effect, but it's also going to be slightly more dangerous to give because that lethal dose is going to be lower. So potency can be safety in both ways. Efficacy is how well the drug produces its effect, how well does it work. And that's pretty much what I have on pharmacodynamics. So what the drug does to the body. Works by receptors. Drugs work with receptors to produce effects. You can have an agonist or an antagonist. And we want to be closer to the ED50 range than the LD50. Any questions on that one? So, CV pharmacology. Some of this I know will be more in your wheelhouse, but it's good for everybody to know. It's what we do a lot in anesthesia. It's when you hear our panic level rising, a lot of it can be related to this. So the way CV drugs work are by altering either the heart muscle itself or basically, I think of veins and arteries as plumbing. It's easier for me to think about. It's less intimidating than thinking about a whole person and all these other things they have wrong with them. When I'm thinking about cardiovascular stuff, it's really plumbing in my mind. So you've got a muscle, and then you've got a bunch of pumps and tubes. If you want to increase inotropy, which is going to be contractility of the heart, how well that heart, which is a muscle, pumps. If you want it to pump harder, you're going to get more out of it. Chronotropy is a fancy word for heart rate. How well can that electrical impulse that goes through the heart work? Can we make it harder? Can we make it easier? People with heart blocks that have slow heart rates or funny rhythms have issues with chronotropy and dromitropy as well. The AV node is a spot on your heart that basically connects your atria and your ventricle. There's a little bit of a delay in that area anyway, but if it gets prolonged, you're going to end up with heart block. I think somebody's covering CV physiology for you guys. There is some in the book on it as well, but basically the AV node is where there's a natural delay that can get better or worse. So lusitropy is a fancy word for how well does the heart relax during diastole, which is the point in the heart cycle that it fills with blood. And you want to get a good fill so that when you squeeze, you get a good cardiac output and inject a fair portion of what's in your heart. And then alterations of blood vessels. That's the pipe, the plumbing situation. So vasopressors equal vasoconstriction. So you're going to tighten up your tube, your pipe, which is going to make your pressure be higher in that system. If you use a vasodilator, you're going to open up that pipe, and it's going to be easier for everything to flow through, and it's going to go at a lower pressure because there's more space in the pipe. These are the receptors that we talked about that primarily work on the heart. And if you, to learn your meds, for me, the easiest way was to figure out which receptor they worked on, and if you know the receptor, you know what the action will be. So alpha 1 is what causes vasoconstriction to your pipes. It'll cause you to tense up, and alpha 1. And then beta 1 and beta 2 are easy to remember. You have one heart, so beta 1. You have two lungs, beta 2, are where those receptors are at and where they work well at. This is a chart from y'all's book that's very busy if you try and memorize it just on its own. If you can look and just really focus on what these receptors work on, which drug works on what receptors, you'll be able to figure out the second portion. So SVR is systemic vascular resistance, which is pretty much how vasoconstricted you are. If you've got a high SVR, you're going to have a higher pressure. If you've got lower SVR, you're going to have a lower pressure. So for people with low pressure, we can increase their SVR, which will make their blood pressure be higher.
What does SVR stand for?
Systemic vaso, what did I just say?
Vascular response.
Yes. Brain freeze. And then MAP is going to be your mean arterial pressure. So that's the average pressure that blood's going to be flowing to your organs throughout your blood pressure cycle. And then CO is cardiac output. And this snapshot is from the CV pharmacology chapter in y'all's book. But again, if you think of, phenylephrine will increase your SVR. It's also alpha-1, purely alpha-1 receptor agonist. So it binds to the alpha-1 receptors, produces a reaction, which is going to be to tighten up those vessels. Therefore, you're going to get a 3+ in your SVR. If you can just think what the receptor does, you'll get to what happens later, what it does to the body. So positive inotropes. We said inotropy was the contractility of the heart muscle. So to have a positive inotrope means you're going to have increased contractility. You're going to have a better squeeze to your heart. The ligands that we have that normally do this are called catecholamines. They're made by your body. They're kind of stress hormones. They're very short acting. And things that are made by your body are what we replace. You've got epi, norepi, and dopamine. All those things are made by your body on a good day. On a bad day, you're in surgery, and your body's stressed out and not making any, or you're out, and we're going to replace them for you. So those are some of the drugs that you'll see us use them for. Phosphodiesterase inhibitors is another class of drugs that are positive inotropes, and milrinone is one of those. So all of these drugs are going to increase the contractility of your heart, how well your heart's pumping, and hopefully that will increase your cardiac output. So epi, that's kind of it's a very effective drug, but it's got some side effects, or kind of bad option. If epi's not working, you're in real trouble, let's put it that way. I'm sure you guys have figured that out. But it primarily works on beta-1 receptors, which are beta-1, one heart, they work on your heart. They also have some alpha-1. So alpha-1 is going to be what tightens up your pipes, which makes your blood pressure go up. It also has some beta-2 effects, which are your lungs. The lung effect is going to be bronchodilate. So it's going to open up the pipes to your lungs, make it easier for oxygen and air and pressure to go in. You'll see, I try to set up these slides similarly so that when you're studying it's a little easier, but so it's the receptor, what we use it for, and then how you can give it. That'll be the same on each of these slides, hopefully. But it's used in cardiac arrest for sure. It's part of your BLS, ACLS algorithm. It's used for low cardiac output, which in the heart tower is what it's used for frequently at the end when they're shooting numbers and they're not quite right. It's also used to treat allergic reactions. You'll get a better heart, you'll get those lungs to dilate out. We'll use it for bronchospasm, again, because it has some beta-2 effects. We will also add it, you'll see, to nerve blocks, local anesthetics, because it does cause those pipes to tighten up, vasoconstrict. You're going to get less absorption of your local anesthetic, so it'll stay in that area longer, and it'll work longer on those nerves. So it can be given, epi can really be given just about any way you can get it in the body. You can give it IV bolus, IV infusion, you can give it down the endotracheal tube, you can give it IM, which is what those kids with EpiPens that are allergic to bees, that's IM epi. And then it can be injected into the neural space. So epi is kind of the mother of all CV drugs. It's potency, but it works well, but it has some bad side effects. It's also our last choice generally. There's not much more to do to. The next list in potency is going to be norepi. So something our body normally makes that we can also replace. You're going to get some alpha-1 action. So that's going to tighten up your pipes, increase your SVR, make your blood pressure go up. It's also got beta-1 effects. So beta-1, one heart, it's going to increase the contractility of your heart. Sometimes these effects can be based on what dosage you're giving. Oops, I didn't hit y'all's slide, did I? Sorry. I have notes on mine, which are over here, that I need to remember. Sometimes what receptor gets acted on more can depend on the dosage. And I did not put dosages on these slides because none of the questions in the book asked you guys about dosages. If somebody wants you guys to give a drug, you make them be real clear about how much they want. And if they hand it to you in a syringe, I would ask, how many cc's of this do you want? Don't let them tell you, I want 50 milligrams. Chances are you have no idea unless they also hand you a bottle. So the easiest thing, if y'all are helping, is to ask how much of it, 1 cc, 2 cc's, 10 cc's. But the dosages are in your book if you want to memorize those. There's wide dose ranges. But again, I didn't see any questions with dosages, so it's kind of less for you guys to have to take in if you skip that part. So norepi, kind of like epi, can have some side effects that are less desirable, so it's not a drug we use every day. By tightening up those pipes, the body will then shunt where it sends blood. Those vessel-rich groups that we talked about, the heart, the lungs, the brain, those places will get flow, but it'll start to cut off flow to other areas, like the peripheral, hands and feet. In some cases, it'll decrease flow to the kidneys and gut if you get it high enough. And that's generally more of an issue in ICU, where they have these patients. We've done surgery on them. They survive surgery. We take them to the ICU on all these drips. If they're on these drips for days and days and days, they can start to have issues of low flow to their kidneys and then their gut. So norepi is used for low cardiac output, shock, and then low vascular resistance heart failure. It'll tighten up, it's alpha-1, so it'll tighten up those pipes and give them more SVR. It's given really only as an IV infusion. It's got a really short half-life, so it doesn't last long once you turn it off. The next sort of ligand that we have in our body, that our body makes, that we can replace, is dopamine. It works on dopaminergic receptors, which are special receptors that work only for dopamine. So they're primarily found in the kidneys. They increase blood flow to the kidneys when we're given dopamine in a low dose. It's for the dopaminergic effects. You'll hear it called renal protective dosing, where we want to make sure the kidneys get good flow during surgery to maintain their function. It also has some alpha-1 effects at different dose ranges, so that's going to tighten up your pipes, increase your SVR. It also has beta-1 effects at middle range dosing, and that's going to increase your cardiac contractility. Beta-1, got one heart. It's also given as an IV infusion. So dobutamine is solely beta-1, works just on the heart. It is a synthetic catecholamine, so it's not made by your body. It's only made in the pharmacy, and then we're going to give it to you. It will increase contractility, it'll increase your cardiac output, but it will not change your SVR since it's not alpha-1, it's only beta-1. It'll increase contractility, therefore your cardiac output. Some of the downsides of it is that it will increase the oxygen needed by the heart, which can be a challenge for our patients that have got coronary artery disease, who the arteries to the heart are clogged. They are going to have a hard time getting oxygen to those muscles in their heart, which could put them at an increased risk for a heart attack intraoperatively. The pro of it is that it increases blood flow to the heart muscle, so it will cause those coronary arteries to dilate to allow more blood, but it's still increasing the demand. So you're trying to be in that middle range where, yeah, we need the heart to work harder, but we're going to try and give it the oxygen it needs to help it do that without causing them to have major issues. It's used for ventricular failure, usually left-sided failure, which is going to result in a low ejection fracture, which is the measurement of how much blood comes out of the heart with each pump. So you want an ejection fracture on average is 60% for your normal healthy person. People who are getting low amounts of blood out of their heart need what dobutamine does. Increases contractility and will increase how much you can get out of the heart with each pump. So, isoproterenol. It's an older drug. It's not used too terribly much. I think sometimes it's used in the EP lab where they do studies on patients with SVT to put in pacemakers. It's, like I said, I think that's the only place I've used it. So it's a beta-1 agonist. It's going to bind and work in your heart. It's also going to bind and work in the lungs because it's got beta-2 effects. It's, like I said, the most potent agonist of beta-1 and beta-2. It causes significant increased oxygen demand with the heart without what dobutamine does by causing dilation to get more blood flow. So it will make your heart beat harder, it'll make it work harder, and it won't give it any extra credit. Can end up with ischemia or an MI. It's frequently used to overcome heart block or bradycardia. And it's given primarily as an IV infusion, and y'all's books that also IM or sub-Q, which I haven't seen in reality. It's usually an IV infusion. So milrinone. It is a phosphodiesterase inhibitor. It leads to basically increased beta stimulation. So it's going to increase contractility of your heart through beta-1. And then it's going to cause arterial vasodilation. So it's going to cause those pipes to open up, become wider, which is going to decrease your SVR. Which is going to mean you're going to get more out of your heart with lower pressure. Occasionally that can be a bad thing. We still need you to have low pressure, but we need your heart to beat harder as well. So frequently you'll see patients on milrinone with also dopamine or some other alpha-1 antagonist to tighten them back up. But it's used on patients to increase ventricular function, especially right-sided heart failure, and it's given as an IV infusion. Milrinone is a drug that you give a loading dose of and then start an infusion. I think that's, how you guys see it in the heart tower. But it works well. It's kind of original thinking that's different about it is that it causes arterial vasodilation. Okay, vasopressors. They're the class of drugs that make your vessels tighten up, so you get narrower, increase the pressure in those tubes. Phenylephrine and ephedrine, everybody's pretty much used in almost any anesthetic unless they're probably under 40 and ride bicycles and run miles every day. So phenylephrine, it's a purely alpha-1 agonist. It's going to cause the veins more than arteries. When you tighten up those tubes quickly, a reflex you can get is a decrease in heart rate. because all of a sudden that pressure goes up really high against the heart and the heart goes, whoa, and slows down. I think it's Bainbridge reflex, there's a smart name for it, but anyway, results in a slower heart rate. So that can be good and sometimes be bad. That's how you'll know when phenylephrine starts working, is you'll see the heart rate go down. It's not specifically working on the heart, just works on those vessels, but a reflex is that your heart rate will go down. It can be IV bolus, can also be IV infusion. I should have added there. Ephedrine, our other good friend that everybody uses almost, touches almost all the receptors. It is going to cause some alpha-1, so it's going to tighten up those pipes. It primarily works on beta-1 receptors, so it's going to increase contractility. It also works on beta-2, so you'll get a little bit of bronchodilation. It's not really what anybody uses it for, bronchodilation. It's generally to increase your heart rate through beta-1. A side effect of ephedrine is that it's an indirect acting vasopressor, so it will cause your body to release norepi that it has stored up in your body. So you'll give ephedrine, you'll get a bump from your ephedrine, then you'll get a bump if they have norepi in their body being released as well. So vasopressin is a very potent arterial vasopressor, and it works on arterial walls. So it doesn't work via alpha-1. It works directly on the walls of the artery pipes to cause them to constrict and increase pressure. It's going to be used for septic shock, cardiac arrest, and then the post-bypass shock. Again, vasopressin and epi and norepi are some of the most potent drugs we have to improve cardiac function. So those are the drugs that are going to improve your heart muscle. You've got alpha-1, which is going to tighten up the pipes, increase your pressure, increase your SVR. Then you've got beta-1 agonists, which are going to improve contractility. Beta-2 drugs are going to cause bronchodilation. And then you've got milrinone phosphodiesterase inhibitor that increases contractility. Any questions about those? They get you beaten, get you tightened up, improve your cardiac output. So antihypertensives are going to be at the opposite end of the spectrum. They're for our patients that come in hypertensive. They thought their pre-op nurse told them not to take any drugs for 2 weeks. No, wrong. So these are the drugs that we use, some intra-op and some at home, to help our patients get their pressures down and improve cardiac function. So nitroprusside, also known as sodium nitroprusside, SNP, it is a direct vasodilator, so it works directly on the venous system to reduce afterload. It's given as generally an IV infusion. Some people will take some out of the infusion and dilute it down and give small boluses because it's incredibly potent. You could cause damage by giving it bolus, so you got to be bold and water it down a lot. It works quickly, works in about a minute from when you start it, and it, because of its potency, it can be associated with toxicity when given at higher dosages and used for an extended period of time. So nitroprusside is a direct-acting vasodilator. Afterload up there is a word that talks about how much the pressure the heart has to pump against. So if you've got high SVR, you've also got a high afterload. So if your heart as a muscle is pumping against something really high pressure, it's going to be harder work. Versus if you have less pressure, your pump works better. If there's any more vocabulary words that I haven't explained, you guys just let me know. Nitroglycerin. This is what Grandpa takes when his heart hurts at home because he tried to shovel the snow. It's also what we can give intra-op. It works directly to reduce vascular smooth muscle, to relax vascular smooth muscle. It works on veins more than arteries, which makes it a little different. It also is somewhat cardioprotective. It decreases how much work the heart has to do as well as increases blood flow to the heart. So it makes it work harder, but it gives it extra oxygen to do the work, which is going to help it protect against MI. It is used for chronic heart failure, and then it's also used to treat intraoperative MIs to helpfully increase the flow and the oxygen to that muscle. I think you guys have probably noticed that sodium nitroprusside is affected by the light, also kind of like LASIK, and that it comes in that black bag to decrease light. The light deactivates it and reduces its potency, which is why it comes in those little black bags. So, more vasodilators. Hydralazine. It is a direct vasodilator, but it works on arteries more than veins. So it works similarly to nitroglycerin. Nitro works more on veins than arteries. Hydralazine works on arteries more. So it's used for acute hypertension. So it's not something most patients are necessarily on at home. We use it in the hospital. It's got a slow onset and long duration, which for us in surgery can sometimes be a negative, that it doesn't work quickly, and you know we're instant gratification people in anesthesia. So, and it also lasts longer. It could outlast our surgery, and then end up working and pack you out on the floor, where they then call the doc and say, hey, your patient's pressure is really low. So it's not always our first choice, but it does work primarily on arteries, which sets it apart from lots of other antihypertensives we get intra-op. So phenoldiphane is a DOPA-1 agonist. It has some alpha-2 action. Alpha-2 is sort of the opposite of alpha-1. It's going to cause relaxation. It's got fast onset as an IV infusion. It has less toxicity than sodium nitroprusside. It's not really used much here in the U.S. It's more of an international drug, but it is in y'all's book. So worth looking over. So those were our vasodilators. The other classes of antihypertensives, we have the vasodilators, then calcium channel blockers, and then beta blockers. So the calcium channel blockers produce vasodilation, reduce arterial pressure, so it's going to decrease your SVR. Then it ends up leading to a decrease in afterload. So it's going to decrease that pressure that your heart has to pump against, therefore making it easier for your heart pump to do its job. It works by blocking calcium release in your heart cells and vascular smooth muscles, which is what makes the pressure go down. Calcium is needed in each individual cell to result in an action. So by blocking the calcium release, that cell can't do its job. So it's going to result in vasodilation and decrease in arterial pressure. It's used for hypertension. It's also used to prevent cerebral vasospasms after a subarachnoid hemorrhage. It's a post-op complication those patients can have. An example of a calcium channel blocker is nicardipine. We can give these intra-op IV. They can also be continued at home as an oral med. And that sort of summarizes calcium channel blockers as a whole. So beta blockers, what's kind of one of our go-to antihypertensives in anesthesia. Beta blocker is going to be an antagonist of the beta-1 cell receptor. So it's going to lower your blood pressure. It's also going to be an antiarrhythmic. If it is a beta-2 agonist, so it's going to bind and really cause no beneficial action, it can result in bronchospasm. So that's like somebody who has asthma and says, oh my gosh, I'm having an asthma attack, I can't breathe. That's because those bronchi that take air from your trachea to your lungs or your bronchus. It's going to cause them to narrow and constrict. So for some people, a beta blocker is not going to be a friend, it's going to be more of a foe. Metoprolol, however, is beta-1 selective. So that means it's only going to bind to the beta-1 receptors. So it's only going to alter your cardiac function. It's not going to irritate those lungs. For patients that are asthmatic, metoprolol is generally going to be a better choice. Labetalol, on the other hand, does all the beta receptors. So it's going to do beta 1 and produce some slowing down on heart rate. It's also going to bind to beta 2 and could potentially cause a bronchospasm. For most people that are non-asthmatic, not respiratory illness patients, it's not a big deal to have a beta 2 antagonist. But for asthmatic patients, it really can get you into some trouble, and then you're going to end up having to treat the bronchospasm with something else. Esmolol is also beta 1 selective like metoprolol. IV, it's very short acting, lasts about 10 minutes. It can be a short coverage period, unlike metoprolol and labetalol that last hours. Esmolol is going to be 10 minutes. So it's a good coverage intra-op to get through some periods of time without committing to a 4 to 6 hour dose of a drug. So beta blockers, they're going to lower your blood pressure. They can also be antiarrhythmics for patients that have unusual fast heart rates. It can slow them down into a more normal range. For an asthmatic patient, you're going to want to give them a beta 1 selective. Asthma patients aren't going to tolerate beta 2. All right, other antiarrhythmics. So an arrhythmia is basically anything other than sinus rhythm. It can be fast, it can be 110, or it can be 220, or it can be slow. It can be a bradyarrhythmia, less than 60. Sometimes those lower heart rates start, well, in either high or low. They can be triggered by any cell in the heart. Can decide to go haywire and initiate its own heart rate. Sometimes those triggers will carry through the whole heart muscle, and you'll get those high rates or those low rates. So these are the drugs we're going to use to treat anything other than sinus rhythm, really. So adenosine is going to cause an AV block. What that AV node is the place in the heart that the beat from the atria goes through to the ventricles. If we can stop that AV node, if passing through an AV node, you can stop that heart rate. It's used for fast arrhythmias like SVT. You have to slam it in there quickly because it's so short acting. Starts acting within 20 seconds, lasts 10 seconds. And what you'll see is no electrical impulse whatsoever for about 10 seconds. And then what the goal is for the normal sinus rhythm to start back up and basically overpowering that little cell that's causing all the trouble. So you give it quick. It'll give you nothing. It'll cause a complete heart block for 10 seconds till that drug's worn off, and then hopefully restart in sinus rhythm. So verapamil is a calcium channel blocker. It blocks that calcium from the cells. It's used for tachyarrhythmias. Amiodarone is used for lots of things. It's a good coverage. It's used for SVT, ventricular arrhythmias, which are usually bradyarrhythmias. They're usually slower. It's also used for AFib and A-flutter. Amiodarone's given with a loading dose and then an infusion, similar to milrinone. You want to get in that therapeutic range and keep it there. We can also give lidocaine. Lidocaine, as a local anesthetic, works on sodium channels. We can use it to work on the sodium channels of the heart as well as what we use it for a nerve block for. By blocking those sodium channels, you're going to delay the heartbeat, that cell being able to refire, so you'll slow that heart rate down as well. And then our other two antiarrhythmics are going to be atropine and glycopyrrolate. So they are competitive antagonists. So they're going to bind and block something. They work on muscarinic acetylcholine receptors. So there's certain receptors throughout the body. They are blocking parasympathetic nervous system activity. So I don't know if you guys have read the fight or flight situation. So parasympathetic is going to be fight. Sympathetic is flight. So parasympathetic also has to do with your vagal nerve. So when you have vagal nerve activity, it's going to result in bradycardia. So what we are trying to do is bind to those muscarinic receptors and not allow that bradycardia to happen. Whatever's naturally binding with it, we're blocking. So by blocking it, we're going to allow the heart rate to be higher. Like I said, both will increase heart rate. Glycopyrrolate's lower than atropine. Atropine is going to be your code drug, your basic life support drug that we're going to give patients. So they will both, atropine and glyco will increase heart rate. They'll stop bradyarrhythmias. Okay, any questions on CV pharmacology? I know that was a lot, but honestly, I think if you think about it as tubing, pipes, plumbing, it's less intimidating to think of it that way. And then think about what your receptors do. If you can remember what receptor it works on, you can get to what action that drug has. And it's easier to remember that way. You don't just have to memorize all these do this thing, all those do that thing. If you can think about why it works, it'll help you remember. Okay, respiratory pharmacology. So we can give an assortment of drugs through the respiratory tract. We give our volatile anesthetics that way. That's why we put tubes in people so that we can, or LMA, so that we can deliver the volatile anesthetics. As I mentioned earlier, we can give epi. Your lungs are big vascular organs. They need lots of blood flow to exchange the gases. Therefore, we can use that to our advantage. We can give them drugs through that vascular area to work on different locations. The lungs do vary in absorption and how much will get to the target organ you want. For epi, we give about 10 times what we would give through the IV is what we're going to give through the lungs. So it's definitely got different absorption. It's going to take a little bit longer, but they're big lungs. You can give more volume. We can give solids, liquids, or gases. Epi would be a liquid. We can give the gases, the volatile agents we use every day. So bronchodilators. These are the drugs that are going to open up this bronchus and allow more airflow to get through and get through easier at lower pressures. There are medications that can cause direct bronchial smooth muscle relaxation. That's what's lining those bronchus. They're going to be beta-2 receptors, which is what beta-adrenergic receptor agonists are. It's a fancy word. Albuterol, that's what kind of our first line defense for a bronchodilator. It's what comes in everybody's box in the little white bag that we do puffs of down the tube. It's going to relax that smooth muscle and allow more airflow at lower pressures. You can also use terbutaline, and as we talked about, epinephrine. I have to practice this word, but methylxanthines like theophylline and caffeine can be used as bronchodilators. And then also histamine receptor antagonists. Benadryl, diphenhydramine, can be a bronchodilator. It's what we give it for allergy patients. It's going to relax that smooth muscle and lower your pressures, more airflow. Bronchoconstrictors. So these drugs are there's not really a drug that's out there on the market to make this happen. Can't really see an advantage to giving someone a bronchospasm or narrowing those, but it is a side effect to a lot of medications. They're going to cause those bronchial smooth muscles to tighten up, which is going to make like a pipe. If you tighten it up, it's going to result in a smaller airway diameter, which is going to increase your pressure, increase resistance to airflow, and then also increase the amount that patient has to, the amount of work those muscles are doing to breathe. So you can see the retraction sometimes, either suprasternal or in between their rib cages, makes them work harder to breathe. So some of the drugs that can cause this side effect are going to be beta-adrenergic receptor antagonists, the beta blockers that we talked about. Propranolol is one. The one we talked about was labetalol. It's a beta-1 and beta-2 antagonist. Drugs that stimulate the parasympathetic nervous system, like neostigmine, can cause bronchoconstriction. And then also drugs that cause a histamine release. Histamine is that chemical that causes the allergic reaction in our body. That histamine release can be triggered by other drugs like morphine, vanco, propofol can do it. Sometimes you can see patients flush after induction on their skin. It's generally due to histamine release. Depending on the patient's airway sensitivities and the degree that happens can depend on if that's going to be a big problem for that patient or not. But bronchodilators, the main thing you're going to see is albuterol. It's going to lower airway pressures, let more airflow in, and it lessens the work of breathing. Bronchoconstrictions, there are no drugs that purposefully cause this. It's a side effect. Makes it harder for the patients to breathe. So, our anesthetic agents, specifically, how do they alter the respiratory system? In general, propofol causes bronchodilation, and then frequently our endpoint is that we want respiratory depression. Paralytics for sure will make you stop breathing, but you can get it done with propofol depending on what your dose range is. Ketamine is not a friend of the asthmatic patient. Ketamine can cause bronchoconstriction. It also makes patients really juicy, makes them have tons of secretions. Our volatile anesthetics, they work through the respiratory system. That's how they're absorbed. Isoflurane and sevoflurane decrease smooth muscle tone in the bronchioles and the bronchi, which results in bronchodilation. So if we can get a patient induced, get some volatile on, it'll relax those bronchi, make it easier for them to breathe. Desflurane, on the other hand, can be really irritating. It smells really bad and is irritating going through the lung tract, can cause breath holding, coughing, bronchospasms, an assortment of unfriendly episodes. That's why we don't use it for pediatric inductions. We use SIBO on those kids because it's a lot gentler on the smooth muscle and the receptors in the airway. ISO takes a long time to do anything, so we don't use it much on kid inductions. But SIBO works relatively quickly and causes a relaxation of those muscles. All right, last big topic, y'all. Neuromuscular blocking drugs. The other thing that we get to do a lot in anesthesia is paralyze people. I thought a picture might help. There's a lot going on in what we call the neuromuscular junction. And the drugs, paralytics work right here in this area. So what you have, this whole system, this whole picture is called the neuromuscular junction. You've got a nerve, and then you've got your muscle fiber. So your nerve is what transmits all the action signals from your brain to get stuff done. The nerve is going to release these little vesicles right here. They're just little areas filled with acetylcholine. Acetylcholine is the molecule that then is released into this open space that's going to come across and bind with the acetylcholine receptor. So you've got your nerve. It's been told to send a message. It releases the acetylcholine. It comes over to the muscle and binds with the acetylcholine receptor site. If it's acetylcholine, it'll trigger a reaction down the muscle fiber to move. If our drug, on the other hand, binds with this receptor, it's going to potentially cause nothing to happen. And neuromuscular blocking drugs are competitive antagonists. So when we give a drug, we have to outcompete the acetylcholine floating around in that area. When we want the drug to go away, when the case is over, it's going to wake that patient up and get them out of there in 0.2 seconds. We've got to overcome how much of the drug we've given. So we want to increase how much acetylcholine is in that area at the end of the case so that those muscles start working again. So your book talks about 2 ways that paralysis can be caused. We could block the acetylcholine release. So we could block right down here so no acetylcholine could come out and trigger the muscle. That's called presynaptically. Or we can block the receptors postsynaptically. The synapse is kind of in this blue area. So presynaptically or postsynaptically at the receptor. There are currently no drugs that block acetylcholine presynaptically that we use in the OR. In the OR, it's all postsynaptic, which involves the receptor. We can come back to this picture if we need to. I like pictures, and it was hard to find pictures for this lecture. But so depolarizing neuromuscular blocking drugs. This is going to be succinylcholine. It binds to the NACH is the nicotinic acetylcholine receptor. That's that acetylcholine receptor I showed you on the picture that's on the muscle fiber. That's the name for that. It causes depolarization of the motor end plate. So it binds to the receptor, causes it to depolarize, so it sends a message down to the muscle fiber. Then it stays bound to the receptor, preventing any more depolarization. So preventing any more signals for the muscle to move. That's what results in our fasciculations with sucks that causes them to wiggle that we wait on. That's saying that the succinylcholine molecule has gotten down to that receptor, bound to the receptor, caused the muscle to fire, and now it's blocking any more firing coming from that muscle. So we should be good. We should be paralyzed. Sucks has a 5 to 10 minute duration of action. So you guys know that. Occasionally with difficult reintubation, we may re-give it. It wears off, so it's safer than if we were to give Rock or Beck. That lasts a whole lot longer. You're pretty committed when you give those two drugs. A side effect of succinylcholine, when that cell on the muscle opens to fire, it releases potassium. And because sucks allows one depolarization, it allows a lot of potassium release at one time. It can increase your potassium level by 0.7 to 1 on our milliequivalents per liter, which is how potassium levels are read, which can be a problem for some patients. Renal patients, it can be a problem for. Patients that have a history of being paralyzed, either from cervical fracture, spinal cord injury, stroke patients, they have lots of those receptors. Even though they're weak and they don't work, the body wants more receptors because it's thinking it's missing something. So with more of those receptors, you'll have more release of potassium. So the downside of sucks is potassium release. Succinylcholine as a molecule looks very similar to what acetylcholine looks like. If you put the chemical structures next to each other, succinylcholine is a mirror image of two acetylcholine molecules. So you have acetylcholine, succinylcholine. It's just two of those molecules. So it's very similar to the natural acetylcholine molecule that we all have and use every day. So non-depolarizing. They do what they say. They don't depolarize. They're paralytics that set in and you don't get fasciculations. They're a competitive antagonist of the nicotinic acetylcholine receptor on the postsynaptic membrane. So we've talked about all those words individually today, and they should make some vague amount of sense. So competitive antagonist. They compete with the natural acetylcholine ligand that our body makes. They work postsynaptically. So they work on the muscle fiber down here, not the presynaptic location. And they block acetylcholine at the receptor. There's no depolarization ever like with sucks. Some of the examples of non-depolarizing are what we use a lot: rocuronium and becuronium. Pancuronium is an old drug that is used in the ICU some, but not really used down here. Do you guys see it in hearts anymore? I don't think so. And then atracurium. As I said with sucks, you're committed when you give these drugs. They last longer than sucks. Sucks is metabolized by the plasma cholinesterase like Remy. Non-depolarizers are metabolized by the liver and kidneys, so they last longer. It also takes them longer to start working than sex does. These are some of the drugs that, like rock, a normal dose of rock that we give is twice the ED95 to 3 times. So we know what that safe dose is that works for half the people. We double or triple it to make sure that we get all those receptors covered. It also, by giving more, makes it work faster. So, but you are committed once you give those. All right, we paralyzed our patient. Yay! 5 minutes later, the surgeon's done. He decided he doesn't want to do that anymore. Time to wake the patient up and get him out in 2 seconds. So the way we reverse our patients, we've got to get rid of that paralytic that's still there. We can't necessarily make you metabolize it faster, but what we can do is give you a drug that's going to increase the natural amount of acetylcholine we have floating in that open space between the nerve and the muscle fiber, that neuromuscular junction area. So we will give an acetylcholinesterase inhibitor. That is a drug that's going to inhibit the metabolism of acetylcholine. So by stopping the metabolism of acetylcholine, it's going to accumulate. It's not going to get broken down and put back in the nerve. It's just going to keep building up in that neuromuscular junction area. If we can increase the amount of acetylcholine in that area, we're going to have more to compete with our paralytic. So acetylcholinesterase inhibitors will increase the amount of acetylcholine in the neuromuscular junction and will increase the competition with the paralytic that's in the neuromuscular junction. We're basically out-competing each other, making it a numbers game, increasing the likelihood that it'll be our acetylcholine, which is our natural ligand, that will cause the muscle to fire and depolarize. A couple examples are going to be neostigmine, which is pretty much what everybody uses, phosphostigmine, and then edrophonium is another one. We primarily, since I've done anesthesia school all 26 months, have used neostigmine, but I've heard that it's going on back order eventually. So edrophonium may come back into practice, which is another drug that's been around for a long time. But it works the same way. They're all different names of drugs that work in the same category. So we've increased our acetylcholine in the neuromuscular junction. Our patient's muscle function starts to come back. They can breathe. Fantastic. It also increases acetylcholine throughout the body, not just in those muscle fibers that we'd like to start working again. It increases acetylcholine in the heart, which can lead to bradycardia and the low blood pressure. It works in the GI tract to increase secretions. It also can increase the motility of your gut to move stuff through quicker, which some people feel like that can increase the risk for post-op nausea, vomiting. You've heard people say, well, I don't want to reverse them because I don't want them to be sick. That's what they're talking about, is this increased acetylcholine in the GI tract. It also works in the lungs and can cause bronchoconstriction. So none of those things are things anybody really wants. We'd like you to have a good heart rate, we'd like you not to vomit, and we'd like you to breathe. So what do? We're going to give an anticholinergic, which is going to be glycopyrrolate and atropine that we talked about earlier that you can use to increase the heart rate by blocking those muscarinic receptors. That's what we are going to give to block. The acetylcholine works at muscarinic receptor sites, so by blocking those, we're blocking the low heart rate, we're blocking the secretion, increased motility, and hopefully protecting the lungs from bronchoconstriction. Any questions about paralytics or reversal? So reversal always has 2 ingredients to it. It's going to have your acetylcholinesterase inhibitor, which is going to be it's going to stop the enzyme that breaks down acetylcholine. You'll get more acetylcholine everywhere in the body. So your muscles will work, but you can also have bad effects at your heart and GI tract and lungs. So we're going to give you an acetylcholinesterase inhibitor and an anticholinergic agent together. Some people mix it in the same syringe, some people give a little bit of this, a little bit of that, a little bit of this, a little bit of that. But basically, you want them to be working together simultaneously to prevent these side effects. That's my last one. I know that was a lot for an hour, you guys. My name and number are back on the very first page. My email address is on there. You're welcome to email me if you come up with any questions later. Pharmacology is something that all anesthesia providers should be relatively familiar with. You know, slightly closer to school they are, they more remember. But you should feel comfortable if you have a question and I'm not around that somebody giving anesthesia should be able to answer that question. But these are the subjects that seem to stand out in your book. I tried to cover it to the depth of what your questions look like. And hopefully I've repeated myself enough that some of it will stick.
Thank you.
Thank you. Thank you.
No problem.
That's just good. She's doing that quiz bowl.
So Jeff, you want me to walk you off?
Can you go over the question I had asked you about the line isolation?